Congress has its own culture and size to it. So to draw extremes, for example, conferences where there's multiple agendas going on at the same time, almost all hours of the day and night. And so, it's a time for cutting edge, high impact research to be presented for the first time often. And you almost have to wear really good shoes because it's like a track meet getting from one place to the other. You do get some time to network with people and catch up on discussions, but often you see someone and then you see three other people and then people are gone, and it's a very different flavor. So smaller congresses have an important role as well because you typically have a smaller, more focused agenda. Everyone's in the same place, we're all in the same place at night, and it's often what I would sort of call the other end of peer review. So if you think of scientific peer review, someone designs a study, it goes to a journal editor who might say, okay, it looks competitive, he'll send it to 3 reviewers, they may ask for revisions, and then eventually it gets published. Some gets published, some doesn't. But still, when it's published, if it's fortunate enough, it's still often the opinion of an editor and maybe 3 other people, 4 other people, depending. But what happens after that is peer review goes on forever. Once it's written, then people get a chance to digest, well, what does it mean? How does it impact? What should be done next? And often that's what goes on at a smaller conference, is where you can actually show the highlights of key studies, or people show their personal data or surgical outcomes, and you try to blend all that together and decide, all right, what's impactful. This morning I gave a lecture on a novel imaging technology that in one cancer I would conclude should stop because it doesn't have any role. In another cancer it's actually routine used, and so you explain how it came to be that way. So I think that sort of highlights, so some of this is scientific, some of it actually is networking. I hate to say social because that sounds like we're just having fun, but there's... It kind of depends on your job practice. So if I was in a busy private practice in the States, it would be a difficult thing to do, or it may not have as much benefit because of the way they're structured. I'm in an academic practice where we're basically given a set period of time every year to try to develop your career. And sometimes that requires getting on a plane and going to another faraway place to see what do they think, what are they doing. I sometimes learn more from other surgeons in their place versus a condensed video in 3 minutes at a congress. So it's a way to supplement what ideas we should be pursuing back in Houston, for example. And part of it's training. The organizer of this meeting was a trainee at my hospital 20 years ago, and so we've kept in touch for many years, and so when he puts together a big program and wants some international support, you're happy to do that. Well, they gave me a number of talks since I came in so far, and so some of the talks you've already given before, and you've shown it to other people. So when you do research, you do want as many opportunities to present it, to explain it. You want it to have impact when it's finally published. You want maybe to have other critiques along the way, things that need to be fixed earlier than later. Other types of talks are more investigative, so they give you a topic where I don't necessarily have the answer on my hard drive just yet, but you give it a couple of months, you dig around. The talk I gave this morning, I actually pulled data from 3 other surgeons, like an investigator type thing, and then you come up and say, well, here's what I found, what do you think? So and then there's always language barrier challenges, but in general most of the Turkish physicians are well rehearsed in English, much better than my Turkish. We go through that. I'll throw in one related concept, is that in some of these smaller conferences where they invite multiple international faculty, it's been my observation that the international faculty sort of gain a special bond because, we listen to each other's talks, we have dinner together, we have time to follow up and discuss things. And I would say that Abby Rain is here from the UK. The opportunity to sit with him for a while is more meaningful here in a smaller international location than if I see him. He's going to host the World Endourology Conference in London in October, and I'll be there. But he's going to have 100 people asking him and pulling him in different directions because that's his meeting. So sometimes meeting him here is more interesting. Well, within urology, what I would find it interesting to explain is that, and actually it's a slide I'll have coming up later today. I mean, there's a discipline of endourology, which is a little bit of a technical field. Mainly, it's you have the field of urology, and now we're going to say, what can you do within urology with minimally invasive tools? Now, there are other areas of urology which are more disease-based. So there is oncology, pediatrics, incontinence, kidney stones, for example. So there's a bit of blended specialties. And so one of my slides will reemphasize the point that a good endourologist needs to be a good oncologist. And a good oncologist, modern times, needs to be a good endourologist. So actually, my training 15 years ago was all structured to do both. I spent dedicated time in oncology. I spent dedicated time in endourology. Actually, it happened to be in Germany, which is why I'm not afraid to get on a plane to go to Europe because I trained in Germany many years ago. So the endourology meetings have a different flavor. They tend to be more evaluation of novel technologies and sort of, I would call it, to me it's a creative thinking meeting, both in Turkish endourology and even global endourology. Oncology meetings have a different flavor to them. They tend to be more multimodal trials, like integrating drug therapy with surgery and long-term comparative trials. You need both, but each group tends to have their focus point. It varies by the procedure. So in prostatectomy in the United States, it's pretty much the technique now. So although if you were an outstanding open surgeon in the United States, you could maintain a busy practice. If you're a young urologist, you pretty much have to master robotic surgery. So the cycle of this, I think, is interesting. If you listen to general surgeons talk about robotic applications, like for gallbladder or something like that, it has the same challenges of urology around 2003 to 4, where attending surgeons were touching the robot for the first 100 cases. Trainees were merely observing. And if you went into practice and had any exposure to the robot, you were considered an expert. So if you fast forward in the prostate world, you can't just have touched the robot. You better have done a few hundred cases. So the bar is quite high in prostate, pretty high in kidney cancer. It's more developing in bladder cancer, for example. But as a result, most of the attendings have I've been doing it 10 years. So I'm confident in where to put a trainee on a step of a case that's beginner, intermediate, advanced, and how to evaluate them over time. One of the themes, it's in robotics, but it's also in other novel technologies, is how to put a price tag on cost or effectiveness, or even just how to draw up measurements. So, for example, I just presented a novel imaging platform that visually on a screen looks fantastic, but it's really hard to show a benefit. It's not that expensive, and so maybe it's something that people do while they're learning if they need help seeing the blood vessels, seeing the tumor. But a highly experienced surgeon can do that normally, for example. Like in my institution, my cardiothoracic surgeon could show you video of robotic lymph node dissection, in the chest where you're right by the heart and you can see it beating in the background. So, you don't want to make a mistake. So he can make the argument that the robot is highly desirous to use there, but I can't really prove it's any different than what I would do with other techniques. So you see that repetitive theme with products that help with hemostasis or help with, ligating structures, things that assist the surgeon. And so you're always trying to figure out how to balance, cost and efficacy. And so sometimes at these meetings, that's an opportunity to evaluate, what people are experiencing. And sometimes people actually do figure out a way to save some money here and there with a novel trick. Well, what we struggle with universally is funding for research and quality, because if an expert gets up in levels of evidence, sort of evidence-based medicine expert, they can pick apart many fields in not just urology but many surgical areas where there's not a lot of high-impact randomized trials to narrate every decision for you. So often you're having to do it with sort of trials of lesser design, and part of that's just quite honestly the funding is different. In the United States, our grant mechanisms from the government are funded at about 10% level, and most of them are, have a favoritism towards, genes and sort of cutting edge molecular medicine, if you will. And we have a big discrepancy in how the industry is organized. So if you are a medical oncologist, there's an enormous pharma enterprise that by law is required to do level 1 evidence. You can't launch a drug without a randomized trial of some sorts. Device manufacturers are more linked to safety. So a company can prove safety and be approved. And so the amount of sort of industry-sponsored research is on a much different and lower playing field. So we're often having to do case series and non-randomized comparisons with some sort of statistical adjustment, and then try to make our best guess. But ultimately, when guidelines are made, they're always going to favor high-level evidence. So it would be great if there were some reasonable funding that people could feel confident if you designed a randomized trial, you could get that funded. And then novel technologies ultimately need to be decided as, go or no go, based on high quality evidence, not just opinions, etc. Other than, specific to Turkey, most of the international congresses are all in English. And so it actually is a good service to have a home team conference for them in their language. They'll translate me and back and forth, but obviously they speak English, but I think they benefit from getting to have a Turkish language. And you'll see actually the organizers of this meeting have put a lot of effort to try to lay groundwork to try to unify sort of Ottoman era countries. Like you'll see there's a special session on from Azerbaijan and in Iran and others that share some heritage features. And then actually the European Urology group knows that as well. One of the international speakers is the head of the EU Southeast Regional Office, Bob Javan, and maybe you'll speak to him. So he's, for example, bringing an official EAU meeting back to Antalya in the fall. So even though they often, and many of the people here come to American meetings, come to European meetings, but this is good for them to have their own. I think so, and it's likely they do on different scales. They're actually and maybe it's somewhat biased by your own experiences, but I find that Turkish urologists are heavily engaged with foreign urologists. They just like it. Frankly, some of the other European countries are perfectly content to just listen to their own. I won't name names. Japan is like this as well. Japan has an extraordinarily organized Japanese urologic meeting where they basically just say, like if they had a 3-day meeting, they just say day 1 is International Day. And they have about 30 guests from the major associations and disease experts. And so they basically have an English language day and get all that done. Then they continue on and do a Japanese language for 2 or 3 days after that. So I went last year. It's really organized in that way. Well, it does help, and I must admit the technology does some of that. I mean, I've been lucky enough to do robotic surgery in many other countries, and some of the hosts are still amazed that, you know, someone can get off a plane, but it's because it's the same system. You know, even with language barriers, I can just go right in and do an operation like it was in my own operating room. In the era, you know, 10 years ago, before robots, laparoscopy was common, and there were major issues with standardized equipment and technique, and most traveling surgeons trying to do displays would bring their own team, their own instruments, because you could never trust what it was going to be there for you. But here, I mean, the robot's the same in any country. I've done it in India, many other places.